Hi folks, John Adamson, the rehab and documentation guru, doing something that I probably shouldn't be doing, but I'm going to talk while I drive. And I'm a typical guy, so we should really only handle one thing at one time, right? Anyway, I want to talk about two patient scenarios. One from earlier and some lessons that really I think most therapists need to know, most PTs especially. And then another one, and this probably benefit both PT and OT, not so much for speech today, but first scenario, went to see a patient, total knee replacement. Now, knee replacements, back in the day, when I first had a job at an acute hospital on the orthopedic floor, back when there was actually like designated staff. You remember those days? Well, maybe you don't. But anyway, we kept our knee replacements 12 to 14 days, and usually hips were 10 to 12 days. Can you imagine? That's insane. That's pre-PPS, of course. And we did a lot of therapy with these patients and did a lot of education and whatnot. But now you've got 2-day stays. Sometimes patients are coming out same day, which is just insane. And I think, frankly, dangerous. One of the common, and I mean common, issues I see is one, just stupid teaching from therapists. So I'm going to pick on some therapists right now related to in the hospital. One, I've touched base on a prior video. Do not crank on your patient's knee. It is not essential to get 90 degrees of flexion before they go home. Not at all. Show me the studies where that is proven to be clinically necessary. It's not. The only thing that's holding a patient back at that point is swelling. That's it. I mean, yes, there's incisional related issues, but the majority of the patient's pain, range of motion limitation, strength deficit comes from the swelling. And so it makes absolutely no sense when a patient's knee is like to crank on them. Because what are you going to do when somebody's acutely inflamed by cranking on them? Well, you're going to acutely inflame them more. And it boggles my mind how many patients are not properly educated on the simple fact of gravity. Gravity is a patient's worst enemy and best friend. So the patient gets home and I ask them on day of eval, are you elevating? And they're sitting in a chair and they've got a little ottoman in front of them. They're going, yeah, I'm elevating. That's not elevation. They've still got their leg below their heart. I'm going to decline this call. They've got their leg below their heart, and their knee is lower than their hip, and their ankle is lower than their knee most of the time. Gravity. Because fluid flows down. And also, so obviously you have arterial pressure pushing the blood down into the limb. But then you have this little problem with your veins. Your veins have extremely low pressure. Very low pressure at rest. So they are not sufficient to drive the fluid back to the heart, especially when the limb is dependent. It's just not working. What drives fluid back to the heart? It's muscle pumping, and it is elevation. And so I routinely tell my patients to elevate for a half hour, at least 3 to 4 times a day, well above their heart. And then usually we end up with this little dilemma. Somebody in the hospital told them, oh, don't put a pillow underneath your knee, only put it under your heel when you're lying down. So what do these patients do? They get in bed, they elevate their leg by the heel, their knee is free hanging, and within 10 minutes they cannot tolerate it anymore. it hurts like the dickens, as it will, because it's inflamed and they're getting tremendous stretch in the posterior elements of the knee. So I have to tell them, I have to uneducate them. It is perfectly acceptable to elevate the leg as long as you're elevating the whole leg and you don't maintain much of a knee flexion bend for too long. But support that whole leg and make sure the ankle's higher than the knee and the knee's higher than the hip, and preferably that knee is higher than your heart. And it will do better. It's not rocket science. I don't know where people get these things. And I cannot tell you a single case where a patient coming out of the acute hospital, I cannot tell you one case where they got proper education on elevation of their limb. Not one. Am I the only one who thinks he's an engineer? Are not physical therapists, are we not educated about physics and hemodynamics? Help me out here. So anyway, that's one patient case. The other patient case, I've seen this guy now for 3 assessments. Initial assessment, he's got CHF, he's got diabetes, he's got PAD, he's got lumbar spinal stenosis, he's got venous stasis in his limbs. He's just a mess, and he's hard of hearing. But he's got a paid caregiver, and he's got his wife. Now, his wife doesn't seem to really care about him. She cares about herself. So invariably, if I bring up something about him, it has to come back to her. And the caregiver doesn't know what she doesn't know. You know, one of the signs of an intelligent individual is the ability to recognize their own intellectual deficiencies. And a morally good, intelligent individual will accept when they are wrong and seek to correct that. I'm just going to say that. On 2 previous occasions, because the main issues I'm seeing this guy are for 1 CHF and then 2 spinal stenosis with radiculopathy, bilateral radiculopathy, I've told them repeatedly, highly educated, both the patient and the caregiver and the wife. I've repeatedly educated them not to, 1, ambulate the patient upstairs, if at all possible. He's got to go up a few stairs to get to his kitchen where he's got his scale to weigh himself daily as he should. And on 2 previous occasions, I've made it extremely clear that they should bring the scale down to where he is. He's living in his living room. And first time I said that, I came back for the second reassessment, and I asked about the scale because I didn't see it. They said, oh, we tried it on this rubberized mat on the carpet and it didn't read. And I had told them on second visit, get a piece of plywood, put it on the plywood, that'll give it sufficient hardness that you won't have that problem. I get back today, the scale's still not there. And they're like, well, we can't work on the mat or the carpet. I kind of lost my cool a little bit. I'm sorry about the sun, by the way, in the video. I lost my cool a little bit with them. I elevated my voice a little bit, and I could tell my frustration was coming out. And I reminded them what I had covered with them on the 2 previous occasions that must be done. One is that he cannot walk much distance because of his CHF. He had cardiac anomalies when he was pushed to that distance, going upstairs to weigh, and there's also a bathroom upstairs. I said, if you have to go to the bathroom, put chairs along his way so that he can rest along the way and fully recover his breathing before he continues. Not done. The other issue is his radiculopathy worsens the further he walks. In fact, we just did a 30-foot walk today, and he started getting significant calf pain, and he gets weakness, especially on one limb. So I had to reinforce on both conditions, from a cardiac standpoint and a back standpoint. It is better to do, one, frequent short walks, not long walks. And two, they must environmentally adapt their home to make it safe and effective for this guy to use the bathroom, so use a bedside commode, which they've got, and two, get him the scale close by where he can use it. Because until those conditions are met, he's going to continue to go back in the hospital, which is what I saw him for a second reassessment because of intractable pain and or CHF. So hopefully they'll get the hint this time. Because if I have to say it again, I'm just going to be like, you're not complying. I'm sorry, but we're now done. And I can say that nice. And I got nice with them after that. I explained, first of all, here's another thing. I had to explain what right versus left-sided heart failure looks like. And the guy's had CHF for a long period of time. They don't know why he's sleeping, sitting up. They don't know why he's got so much edema in his legs. They don't know why his weaker leg has more edema than his more strong leg. This education should have happened a long time ago. I don't know if somebody told it to them, like I've told them things in the past, and they just ignored it. I have no idea. But it's pretty clear that nobody's ever explained these things to them. And I'm just venting my frustration at this point. I'm sorry if you've watched this video with useful information, hoping for useful information, and I've just vented. But hopefully you got something out of this video. So please remember to like and subscribe. Also, if you've got comments or suggestions for future video topics, let me know. I hope you're having a great day. I'm having a great day because I'm about done. I got to do paperwork, and I'm going home early, and we're going on what's called a Bethlehem walk tonight, where they do live animals, live presentation. You walk through the village of Bethlehem. It's pretty neat. They do a tremendous job, and it's free of charge, and the turnout for it every year is in the thousands. It's tremendous. Anyway, hope you're having a great day. Take care, and God bless.